complaints of headache followed by transient loss of consciousness on 28th of August at around 4:30 p.m. He was immediately, in few minutes, he immediately regained consciousness. The headache was associated with vomiting and a gradual increase in weakness of left upper limb and lower limb. There was no history of altered sensorium, seizures, or fever. He was taken to a nearby hospital. Past history was he was known to have hypertension. He was diagnosed to have hypertension 6 months back. Was on regular medication with amlodipine 5 milligrams OD. No history of antiplatelet or anticoagulation therapy or bleeding any bleeding tendencies. He was a non-vegetarian, social drinker, and smoker for 10 years occasionally. No history of any other substance abuse. Course in previous hospital. Patient was initially taken to a local hospital near his residence by 5 p.m. At presentation, patient's GCS was around E3, P3, M5 with left hemiplegia. BP at presentation was around 200 per 110 millimeters of mercury. A non-contrast CT brain was done, which showed right ICH with intraventricular extension and a midline shift of 15 millimeters. Patient was intubated and ventilated. Patient was intubated and ventilated in view of aspiration risk and was started on NTG infusion and was referred to our hospital. On arrival to our emergency, he was protected with 7.5 size endotracheal tube and fixed at 21 centimeters. Was on controlled ventilation with minimal FiO2 requirement, targeting saturation more than 94. Coming to circulation, the heart rate was around 67 per minute and BP was around 160/80 with NTG infusion of 1 mics per kg per minute. All peripheral pulses were felt. Coming to disability and neurological examination, GCS was E3, VT, M5. Bilateral pupils were equally reacting to light. It was basically localizing to pain. Right side, left side dense hemiplegia was there, and deep tendon reflexes were present on right side. Diagnosis: hemorrhagic stroke with left hemiplegia and features of raised ICP with systemic hypertension and minimal aspiration pneumonia.
Wait. Where did the aspiration pneumonia come from? Why is that in your diagnosis?
Ma'am, when he was presenting to our emergency, the X-ray was done, ma'am.
Continue.
Hello, ma'am. Can you hear me, ma'am?
We can hear you, please.
Yeah, ma'am.
Go on.
Yeah, ma'am. In emergency, the BP was maintained with target within 1 hour of presentation with systolic BP less than 140 millimeters of mercury using labetalol infusion. And neuroprotective measures were adopted with head and elevation more than 30 degrees and neutral head position. Sedation was continuing with injection fentanyl infusion and basic laboratory parameters was done, ma'am. This was the CT brain, which was done in our hospital. which was the ICH volume was around 63 ml with ICH score of 2.
What is ICH
Yes.
score?
Ma'am, 2, ma'am.
How do you measure it? What is the importance of it?
Ma'am, with the volume of blood, intraventricular extension, infratentorial or supratentorial, and age, and GCS, ma'am.
Okay.
On this,
How do you score it?
Ma'am, if ICH volume is more than 30 ml, we'll add 1 point, ma'am. If it is intraventricular extension is present, it will be adding another 1 point, and infratentorial will be adding 1 point, ma'am. Age more than 80 years, 1 point, and GCS 3 to 4 will be 2 points, and 5 to 12, 1 point, 13 to 15 will be 0 points, ma'am. This patient is having volume more than 30 ml with intraventricular extension, ma'am.
Tells you what?
Ma'am, ICH score of 2, ma'am.
Yeah. Why are you scoring this? Why are you using ICH score? How does it
No,
help
ma'am,
you?
to predict the mortality from intracerebral hemorrhage, ma'am.
Predicts the mortality. Good. Carry on.
Patient was then shifted to ICU. On arrival, the patient was sedated. There was no change in his neurological deficits. GCS was same as E3, VT-M5 with left hemiplegia. Bilateral pupils were equally reacting, and ONST done showed bilateral 5.5 millimeters. His BP on arrival was around 140-80 millimeters of mercury and labetalol infusion of 20 mg per hour. Neuroprotective measures were continued and neuromonitoring was continued. Osmotic therapy.
At one point, Hariprasad, at one point you said you had started GTN infusion as well.
Ma'am, it was started an outside hospital, ma'am. Once he came to our EMR, we changed it to labetalol, ma'am.
Why did you do that? What's the problem with GTN?
GTL will cause vasodilation, cerebral vasodilation, which will cause increasing cerebral edema.
Good.
So we changed it to labetalol, ma'am.
So suppose with labetalol it is not getting controlled, then what is your next go-to?
Most probably calcium channel blockers, ma'am. The ideal choice was nicardipine, but we don't have nicardipine in our here, ma'am. So we'll be going ahead with nimodipine, ma'am.
Infusion, nimodipine infusion do you use?
Yeah, ma'am. We'll be using nimodipine infusion, ma'am.
Okay.
So we are using nimodipine in our center, ma'am, to control the BP. As Hariprasad told, we don't have. We are using initial labetalol, ma'am. If it doesn't get controlled with labetalol, then probably add-on we are starting nimodipine, ma'am.
Any other choice would you have?
Mostly we'll be using labetalol or nimodipine. Any other choices? Short acting like esmolol or metoprolol. These are all IV infusions were available, ma'am.
Yeah. We also use clonidine infusion.
Okay, ma'am.
But the problem is the heart rate. With labetalol and clonidine together, the heart rate becomes a problem. Anyone else who can share the experience? Do you use any other IV products for good acute control of blood pressure?
Nicardipine is available now in India, which was initially not available, but it is now available in IV as an IV preparation. We can use that, although we have not procured it yet, but we are in the process. So recently it is introduced.
It is available?
Sorry?
Do you know the strength?
No, ma'am. I just heard from that MR who had come that they have made it available. So we are in the process of procuring. So once it is procured, I'll share the strength of the vial on the group also. But it is being made available in India now.
Thank you so much. Carry on, Hariprasad.
Yeah, ma'am. Osmotic therapy with 3% NaCl was started. at 50 ml per hour after giving bolus around 100 ml. And follow-up non-contrast CT brain was taken the following morning. Which showed there was an increase in ICH volume and increase in midline shift now. So subsequently, the neurosurgeon was involved, and in view of increase in midline shift and hematoma expansion, patient was taken up for left FTP decompressive craniectomy and was shifted post-operatively to ICU for further management. Post-operatively, patient was shifted to ICU and was ventilated for 24 hours with deep sedation, fentanyl plus subtracheal infusion before next assessment of GCS. The following measures were taken. Of systolic BP was reduced. Systolic BP was maintained throughout in ICU stay with less than 140 millimeters of mercury with an head and raised to 20-degree neck in neutral position. Euthermia was maintained, and ETCO2 was maintained around 30 to 35. Post-operatively, non-contrast CT brain. Follow-up CT scan was done the following morning, showed persistent midline shift. Hence, anti-edema measures were continued, and neuromonitoring was done with hourly assessment of pupils and ONSD monitoring. On POD1, GCS was assessed E3, VT, and M5 with the persistent left hemiplegia. ICP monitored with frequent clinical examinations and follow-up CT scans aided by ONSD. Blood pressure was maintained throughout the ICU stay with target systolic BP less than 140 millimeters of mercury. And enteral nutrition was initiated on POD1 with the target nutrition achieved on day 5 of ICU admission with the following goals. Target glucose were maintained between 140 to 180 mg per deciliter. And patient was started on thrombo DVT prophylaxis on POD1 with intermittent compressions, and POD5 low molecular weight heparin 40 milligram subcutaneous OD was initiated. Seizure prophylaxis, patient was on injection levetiracetam 500 mg IV Q12 early and was continued for 1 week. After that, we have stopped it now. As patient had developed aspiration pneumonia, the weaning was delayed. Ventilation was done with conventional lung protective ventilation. And prolonged, in view of low GCS and prolonged weaning, patient underwent percutaneous tracheostomy on day 5, which was uneventful, and subsequently weaning was attempted and weaned to BiPAP on day 8. Passive mobilization with limb physiotherapy was initiated on POD2.
All right, now you're going to the rehab part of it. Let's just now discuss about the ICH part of it. So, what are the common causes of ICH in non-hypertensive presentation?
Non-hypertensive, the second most common cause is cerebral amyloid angiopathy and AV malformation, any drug abuse.
So if it is a amyloid or any other vascular AVM, anything, yes, not amyloid, sorry, AVM or any other vascular lesion that you're suspecting, what is your flow chart like? How do you go about investigating and managing this patient?
Ma'am, once by seeing the CT, if bleeding is in, if bleeding is other than the common areas like basal ganglia, putamen, thalamus, other than this area, we'll be going ahead with the CT angiography, ma'am, or MRI plus MRV, MRI plus MRA.
If it is a AV malformation, what will you see?
Ma'am, MRI plus MRA or DSA will be.
What are the characteristic features? How do you classify it?
Pritzler Martin grading.
He already told you, Hariprasad. What is
Ma'am.
Pritzler Martin grading? Okay, to the group, this is important. You should know it. Please refresh yourself with that. Based on the arterialization of vein and vice versa, you have to, there is a grading. Okay. Amyloid angiopathy, what age group do you see? When will you suspect that?
Ma'am,
okay, I don't think you have, yes, it's at a younger age group. I think both of these things you will have to look up. What are the common sites of hypertensive bleed?
Ma'am, capsuloganglionic, ma'am, thalamus, cerebellum.
Which is the commonest?
Basal ganglia, ma'am. Putamen.
Anyway, okay. Then lobar, cerebellar.
Yes, ma'am. Thalamus.
Yeah. So these, even if the blood pressure is not very high, the location of the hematoma should guide you towards a hypertensive etiology.
Okay, ma'am.
So, what are the trials you know of which tells you about the immediate management of these? Pre-ICU management of the hypertensive bleed?
Ma'am, regarding BP control, ma'am. Ma'am, Intract 2 and attached to, ma'am.
What do they say?
Ma'am, attached to the patients with spontaneous ICH, lower blood pressure called within first 24 hours, with mean systolic BP of around less than 130. This both trials were telling about intensive versus standard blood pressure control, ma'am. Attached to on the Interact 2, ma'am. The Interact 2 is telling about the patients with spontaneous ICH. A lower blood pressure goal may have benefit for long-term disability.
What are the agents used?
Ma'am, I didn't get you, ma'am.
What were the agents used to lower the blood pressure?
Ma'am,
okay, now what is the time frame based approach to management of ICH?
Hello, ma'am.
What is the time frame based approach to management of ICH? Present guidelines.
Ma'am, if the patient's presentation blood pressure is, if it is more than 220 millimeters of mercury, if systolic BP is more than 220 millimeters of mercury, the BP should be lowered around within 1 hour. BP should be lowered around 15%, and after 1 hour, within 5 to 6 hours, the BP, the 25% of the systolic BP should be lowered, ma'am. If it is less, systolic BP is less than 220 at presentation, the systolic BP should be maintained less than 140 millimeters of mercury.
What are the other goals to attain within 1 hour?
Ma'am, within 1 hour, the CT and airway breathing circulation.
Does anyone else want to help him out? Other fellows?
Any patient was on any anticoagulants or any antiplatelets, it should be addressed, ma'am. Reversal of antiplatelets and anticoagulants.
One more important thing. get your neurosurgeon involved.
Yeah, ma'am.
What is the surgical importance of management of ICH presently?
Ma'am, the immediate indication for surgery is obstructive hydrocephalus, ma'am.
No.
The second one, cerebellar bleed.
Yes, cerebellar bleed, definitely you have to operate. But if it is
Yeah.
a supratentorial bleed, what
Yeah,
does the present guideline say?
The MISTI trial, ma'am. If it is a supratentorial bleed within within 1 centimeter, minimally invasive surgery, but there is no mortal. The functional outcome is not that much good in that trial, ma'am.
After MISTI, what has recently come up? Why is there so much of interest in surgery?
2 recent trials,
Ma'am?
which has shown some positive signals.
Okay, ma'am.
You said your patient had difficulty in weaning, things like that. So do the recent trials say anything about it? The other fellows can chip in, please. Only Hari Prasad doesn't have to face all the questions. So there is Enrich trial. There is one more. Yes, I'm forgetting the name. 2 trials which came up last.
Trial.
Pardon me?
Trial.
Yeah, so the Enrich talked about the minimally invasive. The drawback of that was it was only in putamen, selected in putamen, and mostly the volume was 30 ml. So we still do not have consensus about the further deep. Basal ganglia thalamic bleed, we do not know. And bigger than 50 ml, we don't know what the outcome is. The switch trial, I think, was the second one, which looked at a decompressive craniectomy without touching the hematoma. Both of them have given survival benefits. The functional is doubtful. In fact, Enrich gave functional benefit, but then that cohort in which the functional benefit was more seen had greater number of lobar patients, lobar hematomas. That from stitch we already knew if lobar is evacuated early on, we do have a functional outcome, better functional outcome. So there is still no guideline as such, but more and more evidence is coming up saying evacuation, even the deeper ones, and early on is beneficial. Anyone wants to answer the next question? Why have the recent surgeries been useful compared to the early on? Your MISTI or your stitch, and name so many of them were there, which didn't show any improvement in ICH. Suddenly, why are almost the similar techniques? Why are these being more positive results? Anyone can answer? So basically, these are all minimally invasive. The damage by the surgery per se has been reduced. So that is a prime factor for a better outcome. And most of them have been very early on. Enrich is less than 24 hours. Earlier, surgery was taken up only after you had exhausted your medical management. So that also goes in favor of a good result. And moreover, a lot of refinement in medical management itself has happened. So BP control up to 140 within 1 hour obviously gives you a better controlled environment for the surgeon to go and operate. These are the benefits. Dr. Gopi, you want to ask?
Ma'am, as far as like my understanding, correct me if I'm wrong, for DICH, they do unless otherwise it's medical management rather than surgical management. as long as if you're able to manage ICP and CPP. On the other hand, despite your medical management, if your ICP is refractory, then probably we need to consider decompressive craniectomy. As I said, large ICH, midline shift, significant mass effect. If it is a lobar ICH, if it is the Jesus is not very bad, young chap, then probably we can consider minimal invasive surgery. The options being endoscopic surgery and stereotactic aspiration. Endoscopic surgery is far more better when compared to stereotactic aspiration. And as I said, the two recent trials which showed us as positive signals. One is the Enrich trial, where they used transsulcal parafascicular ICH evacuation. Through sulcus, they have gone in. As I said, like the damage to the non-affected brain was minimalized. And the surgery was done within 36 hours. And this translated into definitely a significant positive outcome. Similarly, the other trial is the MISICH trial, ma'am. Now, that was done in, I think, in China, ma'am, wherein they randomized in 3 groups, one with endoscopic surgery, other with stereotactic aspiration, the other with conventional craniotomy. Compared to conventional craniotomy, the other two minimal invasive techniques fared better, ma'am. These are the trials supportive of minimal invasive surgery to be considered for lobar ICH, NCHAP, as early as possible within 36 hours.
True.
For
there are many ongoing trials for larger hematomas and for deeper thalamic ones. Many are ongoing, and to my knowledge, even ICMR sponsored Indian trials are on the way, and that will be very interesting to see what the results are. So more and more evacuation, not complete clearance. Even in Enrich, the 30 ml volume got reduced to half, less than 15 ml. Nobody is asking to fully evacuate. You reduce the load of hematoma, that in itself helps. So even deeper, if you're able to manage to reach and aspirate out some, the results might be fascinating to follow up with. So yeah, keep your eyes open for what is happening in recent future. But more than medical management is on the horizon. Hariprasad, in the rehab part of it you were talking about, continue with that. Is there anything interesting coming up on that?
Ma'am, nothing much interesting, ma'am. Passive mobilization with limb physiotherapy was initiated on POD2 and was continued throughout the stay.
When did you start coagulation?
Ma'am, ideally we can start after 24 hours, after 24 to 48 hours, by seeing the follow-up CT scans with whether there is hematoma expansion is there or not. But for this patient, we started on
day 5.
Day 5, ma'am.
That is more or less standard in most operative cases. So, what is the duration of ventilation, and when do you decide to track such kind of patients? ICH patient, which group you will try earlier on, and which you will wait and see if you can extubate them?
Ma'am, in our center will be like once after 24 hours the follow-up CT was done and GCS was assessed, ma'am. By the time if the edema is not that much significant, we'll start weaning from ventilator, ma'am. Depending upon the GCS whether he is able to obey or whether we can extubate, depending upon the GCS, we'll take a call by around 4.
Wait. If it is a left capsuloganglionic, how much GCS improvement are you expecting? What will be the best GCS for him?
Left capsuloganglionic, ma'am, it depends, ma'am. Some patients will be, depending upon the size of bleed, some patients will be obeying, ma'am. But however, mostly 70 to 80% of the time we'll be going ahead with tracheostomy, ma'am.
The left capsuloganglionic is the cohort of patients where GCS is of least importance. At the best, they will be E4. They will be aphakic. They will be left hemiplegic. Most likely, they will be N5. They will not come to obey commands. So then, if the is good. He is fighting on the tube. Will you leave him like that, or will you wait for him to obey commands and then only extubate?
No, ma'am. We'll be going ahead with tracheostomy by third or fourth day, ma'am, most probably.
GCS is not a part of extubation criteria. If the patient has a good airway protection, I mean, he's able to protect his airway and take care of secretion, you may go ahead and extubate.
Oh, yeah.
Anyone in the group has heard of Visage criteria, VISAGE criteria for extubation? There is a good article that has come up in Journal of Neurocritical Care from Indians to Indian authors, which compares two scoring systems, Express and Visage. Very interesting. I think you should read. Looking up at neurocritical care patients, these two are being compared to see how extubation affects. So looking at if the patient has a deglutition reflex and ocular movement, he is able to hold eye contact with you, that's a good indicator that they will have a successful extubation. Because GCS is such a poor factor for us to go by.
Okay, ma'am. Ma'am, what is that criteria, ma'am? Discharge.
Visage.
VISAG. Visage. Visual pursuit, age.
Visual pursuit, swallowing attempts, age, Glasgow Coma Scale, and early.
Yes.
Early.
Another one is Express. Have a look on these two.
Okay, ma'am.
Or maybe even we can have a journal club next time with this. You can ask Dr. Anko to help you out in the journal club with this.
Yeah, ma'am.
Okay.
Next day will be mine.
You were saying about set point trial, ma'am.
Come again?
Regarding tracheostomy. Set point 2 trial, ma'am.
Yeah.
Regarding the need for tracheostomy.
You want to say something, Hari Prasad?
We should be, the take-home points will be like the target BP control and surgical indications and neuro monitoring and appropriate reversal for any anticoagulants.
What is the most quickest reversal agent that we have right now?
Most quickest reversal, ma'am.
Yeah.
Time for anything
here. You have to reverse as quickly as possible. What can
you
use?
Ma'am, PCC. Depends upon the anticoagulants, what the patient is taking. If he's on any warfarin, we can go ahead with the PCC, ma'am. And if it is dabigatran,
which one will you choose, 4 or 3?
Ma'am, 4 factor, ma'am.
Dose?
Ma'am, 25 to 50 international units per kg, ma'am. If it is more, the INR is more than 2. If it is INR is around less than 2, around 10 to 20 international units per kg, ma'am.
Yeah, it should not be a fixed dose that you mentioned. It is based on INR and weight. That should be made clear. And
along with vitamin K.
Correct. For NOACs, or they are no longer newer, oral anticoagulants?
No, Novax, if for dabigatran, if it is less than 2 hours, charcoal wash can be given, ma'am. And and then idarizumab. If idarizumab is available, we can go ahead with idarizumab, ma'am. Or PCC we can give, ma'am. And if it is 10A inhibitors, we'll be giving andexanet alpha, ma'am. If it is available. We have used for idarizumab for one patient. We have used it, ma'am. And 4-factor PCC also we have tried. We haven't tried andexanet alpha.
Is available, but I wasn't sure whether the other two were available here.
PCC is available, ma'am.
PCC is available, I know. The other two,
idarizumab, one MR has given us, ma'am. It's
Once we used a patient for idarism for dabigatran,
Intracerebral for dabigatran, ma'am.
How much
but
does it come to cost-wise?
it's pretty costly. We
Yes, ma'am. It
organized
was around 1.5 lakhs. But he gave it for free, ma'am, at that time.
And it works very well, as good as 4-PCC?
the patient did
Ma'am,
not wake up, ma'am. But
Okay.
or else we can do a renal replacement therapy, ma'am.
Yeah.
If the last dose time intake was not pretty clear, and if you don't have idarism, then probably for dabigatran you can consider renal replacement therapy, ma'am.
Yeah. Gopi, you can continue with the discussion.
Ma'am, regarding CT findings, ma'am, like should we have to rely on those early signs of hematoma expansion, ma'am? Signs like swell sign, blend sign, black hole sign, spot sign.
Here, in the deeper ones, you don't very often see them.
Okay.
Any deterioration, you'll have to do imaging and see for the size, the volume rather than the size,
Okay.
and go by that.
Okay.
From the ICS management point of view, I think Hariprasad, all the fellows for that matter, the trials have to be on the tip of your tongue. This
Okay.
topic is all about what is happening recently and how did we reach here. So all the name of the trials, what were the differences between them, has to be on your tips. And reversal agents, you have to know very well. And the surgical management, where are we? What are the advantages and disadvantages? How will you apply in your scenario? That has to be very important. And then the housekeeping about anticoagulation, mobilization, tracheostomy, all these you have to have a general knowledge about this. So ICH, if you get, there are very few points that you have to know, and it's very easy to get a mastery over the whole topic. So if you get a long question, you should just crack it. This is the easiest topic you can get. Anybody wants to ask any questions?
Dr. Shalini, I would like to add, we should also know the ICH care bundle.
Yes, truly said. I was asking him that in the beginning. He fumbled a little bit, but yes, that care bundle has to come. We cannot miss on that. We just touched by it. We didn't go deep into it.
He almost covered it, ma'am, actually, except for the temperature management. He spelled out BP control, reversal of anticoagulation, glycemic control.
Yes.
Dr. Gopi, the thing is, he knows, but he doesn't know in which heading to say that. That is
Okay.
his problem. He
Yes,
knows
that's what
everything.
I'm saying. He knows, yes, correct. But that heading of ICH care bundle, it should be known.
Based on interactive
Yes,
trial.
yes. Even in the control of blood pressure, before, yes, we can add any antihypertensive, as you say, but we should also see whether the position of the patient is proper. The ICP control should be seen. Plus, if the size, if it is analgesic, should be whether the patient is proper sedated. With just adding antihypertensive or controlling blood pressure, instead of that, we have to see as a patient entire. Okay. So we should also keep in mind all these things.
Also, very often, this cohort also has an underlying renal problem which goes undetected. They might be coming to you for the first time with a creat of 1.5, 1.6, and then it just keeps on creeping. Underlying renal disorder has to be taken care of, investigated, and corrected. Otherwise, indiscriminate use of antihypertensives, the choice may not be appropriate for underlying disease. So, ruling out renal condition becomes very important, especially when they present with ICH. You can explain about your take-home points, Hari Prasad.
Yeah, ma'am. Ma'am, the target BP control, we can control the target BP control once the patient presents to ER. The systolic BP should be, if it is the BP is more than 2, if BP is less than 220 millimeters of mercury, systolic BP, it should be controlled with labetalol infusion followed by bolus infusion followed by infusion around the BP should be maintained around systolic BP at the initial stages. It should be maintained around 140 to 160, and with adequate sedation and other neuroprotective measures, ma'am, like head and elevation, head in neutral position, adequate sedation, and if after securing airway, if need, if airway is under aspiration risk or any low GCS, and the surgery indications are like if the immediate indications are cerebellar hematoma and obstructive hydrocephalus and large ICH if it is more than 30 ml. And we should see whether the we should detailed evaluation of history should be done, whether patient is on any antiplatelets or anticoagulants, and if there is anything like antiplatelets or anticoagulants, we should be reversing that thing, as said for Novax and warfarin. And antiplatelets, if needed, will be giving a platelet transfusion, whether single donor platelets or random donor platelets, and a frequent strict neuro monitoring should be there. All other routine ICU care should be maintained, ma'am.
So a very
The follow-up
precise
CT.
manner of going, very precise manner of going about describing the management of ICH would be your immediate medical management, which involves predominantly your BP management.
BP. Okay.
In that, when you start off with your IV infusions, you should also mention the choice of short-acting oral antihypertensives. So, what would be a short-acting agent you would want to consider?
Clonidine. Oral you are asking right now.
Yeah.
Oral will
IV
be
infusion. IV
IV
infusion you cannot go on for long. You will also need
yeah, ma'am.
supplementation.
Will be within 24 hours. Will be weaning off the IV infusion and will be going ahead with the oral antihypertensive. First line will be calcium channel blockers, ma'am. Second one will be like clonidine, centrally acting, and third line drugs will be like will be going ahead with the prozosine. And
whatever you use, it should be short acting. You can't have the long acting.
Yeah, ma'am. We'll be going ahead with short acting.
They say the variation in blood pressure is very important. That should not be smooth, sustained drop in blood pressure, and we need to sustain it for at least 24 hours.
Okay, sir.
The second heading would be your surgical approaches. Third should be hematological management. So, have you heard of Stitch trial without the STICH?
Yes, ma'am. Stitch one.
Not Stitch. There is no STICH. What does that trial tell you about?
Stitch, ma'am. Tranexamic acid.
Correct. What did it tell?
There is a in intracerebral hemorrhage. There is a 1 gram of tranexamic acid reduces hematoma expansion, ma'am.
So there are other agents also being tried. So you have to give a sneak peek about what is happening there. Then
you have to give 1 gram over 10 minutes, followed by 1 gram over 8 hours. It would.
Yes. Go ahead, Nandakumar.
If you give, it can be reduced in hematoma expansion. The yearly death will be decreased, madam. There is not much complication was not there. Adverse effects were not there, madam.
Yes. But then it was a very small cohort, and it needs a larger trial to really become a guideline. So see, unless you came to the point of controlling the hematological expansion, you would miss this trial. It gives a very good, very systematic point of view of management. The examiner will be impressed with you. Last point thing is neuroprotection. In neuroprotection, what is helpful as of now? What is being tried and what has shown some positive findings?
Physiotherapy, cognitive
Magnesium is
behavior
being
therapy.
tried. Come again?
Physiotherapy, cognitive behavior therapy, social therapy.
Good. That becomes rehab.
Yes, ma'am.
That is the next stage. Yeah, that is next stage. In neuroprotective, magnesium infusions are being tried and magnesium being pushed to a little above the normal value. Same is happening in subarachnoid. Most of the intracerebral bleeding, parenchymal or subarachnoid, magnesium has a lot of role to play. So this is all over. Again, some interest in magnesium is coming up. And in ICH, magnesium infusions are being tried and has the preliminary level shown some interest. The final results when it comes will be nice to follow. So you divide, and then of course what he said, neuro rehab. You divide your whole approach in this systematic manner, you won't miss out anything. There are some 4-5 trials in each of these headings to go by. That gives you a complete coverage of the topic. Nandagopal, you have something more to say?
Nothing, madam.
Dr. Gopi?
Nothing, ma'am. Like as very well said, ma'am. Like the initial management, basically they say there are two injuries. One is a primary injury and second injury. Primary injury is like in early, probably from the time of symptom onset to 6 to 8 hours of time. Above 8 hours, it is more of second injury. Primary injury predominantly due to mass effect, ma'am. Whereas secondary injury is due to rise ICP, edema, inflammation, all the stuff, ma'am. So to prevent the mass effect, if we can contain the hematoma expansion by BP control or reversal of anticoagulation, that should be done as early as possible at the earliest. Apart from that, second injury probably controlling the temperatures, glycemic control, all your supportive cares. Those stuff should help us to handle the secondary injury. Now. And despite medical management, like if you can reduce the load of the clot, which is a determinant of a long-term disability by means of minimum invasive surgery, probably those stuff, surgical management, which should help us in the long run.
Exactly, well put. Other fellows, anybody has any questions? Please clarify now. Nothing in the chat box. Thank you, Prajakta. That was very, very useful message you put. That nicardipine 2.5 milligram per ml strength, 10 ml ampule. Initially to start with 2.5 milligram per hour and titrate till 5 milligram per hour. Thank you.
Thank you, ma'am.
Thank you.
All right, thank you.
Thank you.
We had 22 participants. Thank you very much.
Ma'am, I have shared the vial photograph on the FNCC group also.
Great, thank you very much.
Yeah.
Ma'am, can you
We
just
shall wait
share
after
all the
40.
trials, ma'am, pertaining to the recent trials, ma'am?
Yeah. I will put it up in the FNCC group tomorrow.
Yes.
I'll make a chart of it and I'll put it.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, everybody. Good night.
Thank you, ma'am. Good night.
Thank you. Thank you.